Welcome to Preparing for the Late Stage. So I want to say a few words about today's program and how this is going to go. Ideally, all of the participants should be muted. I have set it such that when you enter the Zoom chat, or excuse me, the Zoom room, you should have been muted, but I am learning that some of the settings sort of come and go. So please keep yourself muted if you find that your settings adjust themselves as we go along. And we won't be participating via video. So you're welcome to just find the stop video option in your menu if you don't want to be viewable to the rest of us. So if you have not already, please go up into the More menu, which should be either up at the top or the bottom of your screen, and find the chat feature. And that will open a box that looks like this, like what you see here on the screen. And when you type messages in there into the chat, the setting is such that only I will see it. So I will receive your chats. If you haven't already, send me a quick chat. Let me know that you're here and that that function is working for you. And we'll be using that as we go along. This is how you can submit questions to me. I'll be able to sort of see them and potentially answer questions as I go, but I'll also be pausing a couple of times during the program to take questions. So just chat them to me, I'll get them, and we'll address them one way or the other. I do want to let you know that this program is being recorded, but only the slides are viewable in the recording and my voice over it. So your names, your video, and your chat is not viewable in the recording. Just want everyone to be aware of that. I do recommend for this particular program, if you don't already, to grab a piece of paper and something to write with, because I'm going to be asking you to do a couple of reflective exercises. It's strictly optional. You don't need to do this, but it might be helpful to you. If you would like a copy of the slides from which I am speaking here this afternoon, please send an email to education@alzsd.org. We'll be happy to send those to you. We don't require registration for these Zoom classes. As you can see from this very pared down format, we're trying to keep the format very simple while we all get used to doing online education together. So I don't have your information, your registration information. So please just send an email if you'd like a copy of the slides. I'll be more than happy to send those to you. And finally, I'll just ask for everyone's patience. This is only our second online education program at Alzheimer San Diego. And like all of my colleagues, I'm working remotely and getting used to all this new technology. And I am here alone and do not have technical support. So this is why I've kept the format pretty simple. If you are having any technical problems, difficulty with audio, video, please don't get frustrated. Again, a recording of this program will be made available. We'll post it to our website as soon as we can. We'll be happy to send you slides. And as always, our social workers are available. So if you've got a question that you have difficulty asking today, please don't worry. We're going to be here and we're going to be available. So let's go ahead and get started. For those that don't know me, my name is Amy Abrams. I am the Director of Education with Alzheimer San Diego. And Alzheimer San Diego is a local nonprofit organization. We're headquartered in the Kearney Mesa area, but we serve individuals throughout San Diego County or people outside of San Diego County who care for someone who's here. And our mission at Alzheimer San Diego is to help families today while we support efforts in finding a cure for tomorrow. So here's our agenda for today. We're going to talk about the brain changes we can expect to see in the later stages of Alzheimer's disease and other dementias, and the physical and functional changes that they cause. We'll talk through some strategies for staying connected throughout the disease and ways to provide personal care and comfort as the disease is progressing. We will be talking about the transition to the end of life, what you can expect, and resources to help ensure that it's as comfortable for both of you, for all of you, as possible. And along the way, we'll be talking about ways to cope with the array of emotions that you may experience as the disease progresses. I just want to take a moment and sort of acknowledge these are difficult subjects to talk about at any time. And this type of an online forum where we can't see each other and connect more personally as we would have if we'd been able to meet in person this afternoon as we had planned, it does make this particularly challenging. But I think if the coronavirus pandemic is teaching us anything about ourselves here, it's that we can do hard things. So I appreciate everyone coming today. So let's start with a quick review of the physical and functional changes that we might expect to see in the late stage of the disease. We'll start by kind of defining what exactly we mean when we say late stage. Some of the common questions that we receive from the families we work with at Alzheimer's San Diego are, how will we know when it is the late stage? What does that mean exactly? How long is it going to last? What will it look like? What symptoms will the person that I care for experience? And unfortunately, it's very difficult for any of us, medical providers, researchers, and even those of us who specialize in caring for people with dementia. It can be very difficult to predict what the entire disease process is going to look like, especially the late stage. What we can say about it is that it is typically a long, slow progression over time. You see this graph here has no numbers, right? We generally say it can be anywhere from 2 to 20 years from the time of an initial diagnosis to the end stage, to the time of death. But person to person, there's so much variance that the numbers are almost meaningless when we talk about averages and time spans. These diseases are highly varied person to person. Generally speaking, at Alzheimer's San Diego, we use this very simple staging model of early, where the symptoms are mild, the middle stage, where the symptoms are moderate, and the late stage, where the symptoms are severe. And we use the general benchmark of how much assistance a person requires with what are called the activities of daily living, those basic tasks that we all need to do every day. Getting up, transferring, moving around, ambulating, bathing, grooming, getting dressed, feeding ourselves, toileting, those basic activities of daily living. In the early stage of the disease, generally people do not require assistance with these tasks. In the middle stage of the disease, as the symptoms have become more moderate, they require some assistance. That could be physical, or it could be just reminders or verbal prompts. And in the late stage of the disease, we will typically see that people do need assistance with most, if not all, of those activities of daily living. The late stage is typically the shortest. In that 2 to 20-year time span, for most people, the late stage will be the shortest of those 3 stages. But again, that can be very difficult to predict person to person. Let's have a very brief look at the different regions of the brain, a couple of key regions of the brain, and the functions that they serve. I'm going to move my cursor over here, and I hope you can see. The temporal lobe here is where Alzheimer's disease and most forms of dementia tend to start. And when there's symptoms there, we'll see this is where short-term memory symptoms begin, because that's the region of the brain that is responsible for creating and encoding short-term memory. Typically, in the Alzheimer's type of dementia, which is the most common, we will then see the disease, the pathology spreading into the frontal lobe regions of the brain. It's that yellow region that you see there. Then over toward the crown of the head into the parietal lobe, spreading, I should say, into the occipital lobe, the pink region of the brain. And when the disease is in the late stage, most forms of dementia, by the late stage, there is pathology in the cerebellum, that region that you see there at the base of the brain, and the brain stem, this little region right here. When there is disease in these two regions of the brain, the cerebellum and the brain stem, this is where we tend to see the person beginning to transition into the late stage of the disease and potentially transitioning toward the end of life, because the cerebellum and the brainstem do control so many of our essential bodily functions. The cerebellum, along with other lobes of the brain, is very involved in our fine motor skill and our larger muscle control. So our ability to control our large movements, general balance, as well as a lot of our speech is managed in this region of the brain. The brain stem is the part of the brain that sends messages to our esophagus and tells us, okay, what's coming down the pipe here is a liquid, it's a bit of food, it's air, right? It's the region of the brain that is telling your esophagus what to do. This is air, send it to the lungs. This is saliva, swallow it. Right? So when there's damage in that region of the brain, we're very likely to see more difficulty with swallowing. We'll see more coughing, more sort of coughing and choking as people are drinking thin liquids or trying to swallow larger pieces of food. The brainstem is the region of the brain that is sending the key messages that regulate a lot of those essential bodily functions that you see listed here, regulating our body temperature, controlling our digestion, regulating our sleep cycles, and then of course the essential functions, heart and lung function, and keeping us breathing. So what does all of that mean? That's what's happening in the brain. Functionally, what does that actually look like? In the late stage of the disease, there's some common changes that we're likely to see. It's not uncommon at all for people to have very limited verbal communication. Not everyone. Again, I want to emphasize here that every person will experience this a bit differently. But limited verbal communication is very common, and it's likely that the person will be down to just a few words or sounds toward the end of the disease. As I said before, we absolutely have to anticipate that the person will require 24-hour supervision and assistance with all of their personal care. It's not to say that there won't be daily care tasks that the person can manage on their own, even in the very late stage. But we do have to plan for a need for 24-hour supervision. As I described, we're likely to see difficulty with chewing and swallowing in the late stage of the disease, and very little physical activity is pretty common. Not being able to ambulate or transfer independently is pretty common. So take a deep breath here and just acknowledge that grief is to be expected here. We're going to be talking a bit more as we go along about living and coping with grief, but for now it's just important that we recognize it. We tend to think of grief as something that we experience or that we will experience after we've lost someone. But Alzheimer's disease and other kinds of dementia are different, right? In these caregiving experiences, we are very likely to feel grief all along the way at every stage of this journey. And so too will the person with dementia if they've got insight into the losses that they're experiencing. So a wonderful psychologist named Pauline Boss, who pioneered a concept that's called ambiguous loss. I really recommend looking into some of her readings and lectures if you haven't come across her yet. Ambiguous loss is the type of loss that we experience when someone is both here, but they are also absent. So this is the type of loss she describes it in terms of people who are, for example, missing persons or people who lose someone in a natural disaster. We don't exactly know that the person is gone. We don't know what has happened to them, but they aren't with us. We've lost them. And dementia does produce feelings of ambiguous loss for a lot of care partners. The person is physically here with us or wherever they live if they're not usually physically with us. But in many ways, they're absent because we've lost our old ways of connecting, our old ways of communicating. The relationship has changed so dramatically. I just want to acknowledge that this particular form of grief is often very impactful for the friend or the family, anyone who's supporting a person who's living with dementia, and it's real. Grief presents in many different ways. People experience it on different timelines. Some people have very physical experiences of grief. There's pain, there's difficulty with sleep. For some people, it is primarily emotional pain, sorrow, anguish. Many people will feel angry in their grief. There's no one way that grief happens. And again, it is to be expected, and we'll keep talking about it as we go along. So I want to take a quick moment here and pause and see if there are any questions that anyone has. Go ahead and drop them into that chat box if you haven't found it yet. Any questions? I'm going to be moving on. The next topic will be talking about communication and getting into some of the aspects of caring for a person with dementia. Just want to make sure we don't have any questions on the physical and functional changes that I've just described. Okay, looks quiet. Please just as we go along, feel free, drop those questions into that chat, and I'll either weave them in to the presentation as I go, or I'll be pausing like this to answer those. So don't worry about being on topic if you have a question about another subject. Okay, so let's talk now about these strategies for connecting and communicating as the person's ability to use verbal language is changing over time. It's very important. I just spent our first few minutes here talking about all of the various losses and changes and all of the different ways that a person in the late stage of Alzheimer's or another form of dementia will experience decline. But it's also important that we remember all of the things that the person can still do in the late stage of the disease. We really believe in this at Alzheimer's San Diego, looking at what abilities remain. A person will absolutely be able to retain a sense of one's environment, where they are, if not fully engaged with the specific location of where they are. A person in the late stage of dementia can communicate to us that they know that they're safe, that they know that they are loved, right? That they know that the people around them care about them, that level of being able to sense and feel one's environment. Person in the late stage absolutely can respond to words, to sounds, to the tone in our voice, to the expression on our face, or just in the words and the tones that they're hearing for us. We absolutely can continue to connect emotionally long after we can no longer connect verbally. So to that point, keep in mind that the person will be able to connect and respond to all types of sensory stimulation. And we'll talk a little bit more about this as we go along. So I have a little exercise for you. Open up your chat box, and if you haven't already, pull it up and send to me a word or a phrase that you might use to describe this person. What are some things that we could guess, that we could know about him, that we could guess about him? Send a chat. Let me know. So we might guess that this is a person who loves gardening. He likes nature. He's happy. He's content in his environment. Looks like he has a sense of humor. He feels happy and at peace. Not sure if I said this one out loud already, but he loves gardening. Yeah, he's whoever he's with, whoever he's looking at there, he's happy to be with them. He enjoys nature. I like it. Generous, friendly, and accommodating. This is a loving person. Yeah. We might say that this person cares about his physical appearance. I think he looks very nice, right? He's in a nice shirt and he has a nice watch on and his hair is nicely groomed. Maybe he is somebody that really loves the feeling of warm sunshine on his face. Maybe this is a person who is ambulatory. You can't tell. Did he walk there? Is he down on his knees? Is he in a chair? There's lots that we could guess about this person. Thanks for participating in that with me. I'd like to ask you to take a moment, take out that piece of paper if you have it, and think about the person that you care for. So every person, regardless of their physical or cognitive abilities, has unique characteristics, things that make them special. People, places, and activities that they've enjoyed, a unique personal history. They have a particular set of values. And there's all those little things, their little preferences, the things they love, their favorite smells, a favorite song, a movie that always makes them laugh. Take just a quick moment, and you can keep jotting these down as we go. Think about the person that you care for. Think about what those things are for them. A favorite song, a smell you know they love, whatever that might be. Just keep thinking about those things as we go along here. And I want to encourage you now to think about those things that you know about that person. What nonverbal strategies might you use to connect with that person? So think about, I've provided for you here an overview of a few of our various senses. Think about the ways that you might engage your particular person through touch. Do they love pets? The feel of a fuzzy cat on their lap? Do they like the feel of certain fabrics, their favorite blanket or a cashmere wrap, for example? Feel free, by the way, to drop me a chat and tell me if you're coming up with any ideas for your person as you think about these strategies for connecting with them through the senses. Sight. Is there a particular movie that they love to watch, cooking shows or the Travel Channel, or a favorite movie? A window that they enjoy sitting in front of? A drive that you could take them on to a particular location that they'd love to see? Are there particular smells that they enjoy or that might trigger a nice emotional memory? The smell of chocolate chip cookies. Ooh, I'm seeing Christmas music. Looking at clouds, I love it. Yeah. So the smell of baking cookies or chicken soup, lavender, mint. Mine is citrus. I love the smell of citrus. What are those smells that you might use to connect and engage this person? Of course, that's for many of us closely connected to our sense of taste. Think about particular foods that they've enjoyed. Or that you've enjoyed together. Think about old favorite meals and recipes or snacks, things that they might be able to continue to enjoy. And then sound. I think sound is probably one of the most powerful ways that we can connect and communicate with people in the very late stages of the disease. There's a lot of options for using sounds to connect with people. The sound of running water is very soothing to a lot of people. The sound of bird song. and really importantly, music. Music is a very powerful way to connect with another person. And I encourage you, if you don't already know, if you don't already have a list going or a playlist going of favorite songs, this is a wonderful sort of tool to have in your toolkit. A couple of songs you know they love that you can listen to, that you can just easily pop on in a moment of stress or anxiety for either of you. Taking somebody back to an emotional memory through a particular song that they know can be very, very impactful. So thank you for sharing your ideas with me. Please keep writing down those ideas on your notepad as they're coming up for you, and we'll keep going here. So keep in mind that people that are living in the late stage of dementia can and do experience a wide range of emotions. I think we tend to focus very heavily on verbal speech for communicating, for making jokes, right? For producing laughter and connection. But keep in mind that it can be sort of a one-way verbal communication. You can tell jokes, you can tell funny stories, you can just start laughing, right? Often the person with dementia can enjoy and respond to you being funny, you laughing at something, whether or not they're able to jump in and join in with you. So don't hesitate. I sometimes refer to this as sort of the caregiving monologue, right? Talk about your day, chat, tell funny stories, tell jokes, and recognize that while they might not be able to engage in the banter with you, they're probably really going to enjoy your experience of that humor. Remember that in these sort of day-to-day moments with a person who's in the late stage of dementia, our focus should be on creating and enjoying those moments, not trying to create memories. You will become the holder of those memories. Let them just enjoy the moment with you. So let's talk a little bit about some key communication strategies. And I'll just make a quick plug here for our communication skills class. This is one of our core education programs, and we will be offering it online again on April 7th. So mark your calendar if this would be useful to you. But a couple of quick points on key communication strategies to use in the late stage of the disease. And I am speaking specifically of verbal communication here. Slow down your speech, speak as clearly and as directly as you can. You may need to shorten and simplify your sentences or even just speak in phrases. It's really okay if you're just speaking in short phrases, short expressions, a few words at a time. Slow your speech down. Don't fear the pauses in conversation. Give the person extra time to respond to you, if in fact they can respond to you. Don't hesitate to use pictures, photographs, food, music, other types of props to sort of guide your interactions with this person. Do be aware of your physical approach, recognizing that many people in the late stage of dementia have a very narrow field of vision. So they don't have a very wide peripheral view. So as you are physically approaching the person to come and interact with them face to face, just be aware that they may not remember that you were in the next room. They may not see you coming around the corner. They may not know that you're there until you're pretty close. So do be aware, moving slowly, gently, making sort of gentle physical gestures, and making sure that the person sees you and knows that you're there before you're really close to them. Being mindful of that physical approach. And while you may be doing plenty of speaking, they may not. So do be watching and listening for those nonverbals that they might be giving you, facial expressions or a behavioral expression, showing you in some way that they like or do not like what it is that you're doing. We'll talk a little bit now about strategies for providing comfort and assisting with physical care for the person with dementia. It's really important that we not assume that because someone isn't clearly asking for something, they don't need it. And I've cared for many people living in wonderful residential care facilities who the staff sort of set a pitcher of water or a glass of water there at the table or at the bedside, assuming that if the person is thirsty, they're going to pick up that glass and take a drink. They're going to get some for themselves, right? Recognize that the person with dementia may not be able to recognize when they have one of these basic needs: hunger, thirst, the need to eliminate. They might not be able to interpret what those visits, not that they don't feel hunger, thirst, or the need to eliminate, but they may struggle to recognize what those sensations mean. Or they may know perfectly well what it is that they need, but they may be unable to meet that need for themselves. So don't just set down the glass of water and assume that they're going to take a drink when they feel thirsty. We may need to be keeping an eye on those unmet needs. How long has it been since that person ate, took a drink of water, or last used the restroom, for example? So I have listed for you here some of the most common needs that we see people in the late stage of dementia struggling to express, to help you hopefully be able to identify these on your own if you see them. Those basic needs: is the person feeling some physical pain, discomfort, the need to move? We'll talk a little bit more about movement here in a moment. It's a really important aspect of quality of life for all of us. Is the person tired, or are they restless? It's not uncommon, where I was talking about those changes in the brain stem that make our sleep and wake cycles irregular. So if the person is being kept awake when they're really tired, that could be what they're craving. I need a nap, or I'm anxious, I'm bored, I'm socially isolated, and I'm restless, and I need to get up and get moving around. So think about all of these physical needs, but also think about personal comfort needs. So here I encourage you to think about yourself for a moment. What are the key things that make you really comfortable, for example, when you get into bed at night? Right? Do you like to have a fan blowing? Do you like to have a window open? Do you feel strongly about wearing socks or not wearing socks to bed, for example? Do you like it warm? Do you like it cool? Do you like to have a nice full belly, or do you like to be a little bit hungry? Right? What are all those specific things that you need to be comfortable? Now try to think about what some of those personal comfort needs might be for the person that you care for. If you don't know them, it may take some experimentation, but these little things: socks or no socks, scented lotion versus unscented lotion, for example, the smell of coffee in the morning, those types of things. Those personal comfort needs can go a long way to keeping a person comfortable day to day. So in actually addressing these needs, remember that behavior is usually a form of nonverbal expression. So thinking back to those unmet needs, right? Usually if we're seeing grimacing, if we're seeing agitation, if we're seeing combativeness, it is typically a person telling us, I need something and you're not figuring it out. So look for those nonverbal communications. Watch for changing facial expressions, repetitive movements. Right? Somebody that is tugging at their waistband, for example, might be saying any number of things. They might be full, they might have a stomach ache, they might need to use the restroom, their pants might be too tight or just uncomfortable. Right? We can't rely on the person with dementia to communicate these unmet needs for us. Do keep in mind when you think about this long, slow progression over time that I've been describing, we don't typically see a really sudden drop in a person's function that just happens overnight or in the matter of hours or just a few minutes. The symptoms of dementia do typically, while there's some ups and downs, and people have good days and bad hours, right, when they're tired or hungry or whatever it might be, typically we don't see people lose their function or a really dramatic spike or change in agitated behavior, for example, in a very short period of time. That's not a normal progression of these diseases. So when you see a sudden change, we don't want to just chalk that up to, well, this is a person living with dementia. We want to let their healthcare professionals know, right? This could be evidence of an infection, a urinary tract infection, the beginning of a cold. It could be early pneumonia. The person certainly could have some type of a cardiac incident, for example. Maybe there's a stroke if they lose speech very quickly. I'm not intending to be frightening. I just want to say when there are sudden changes, it's not a typical progression of the disease. It usually means something medical is going on with the person, and we want to talk with their healthcare provider about that. So all of this takes a lot of energy on your part, right? Being vigilant, providing all of this physical assistance. It's really important that you have a backup plan. So I have here for you a visual of those basic activities of daily living that I was talking about. The big six, we think of these as, we talk about these sometimes as the things we all do when we first get out of bed in the morning. Right? Maybe not in this order, but eating, bathing, dressing, transferring, meaning getting from a lying to seated or a seated to standing position, toileting, managing our own continence, and then ambulation, walking around or just moving around with assistance if it's needed. Remember that the late stage is defined by the person's need for assistance with all or most of these tasks. So it is very important that we be thinking now about how we're going to meet them. Hands-on assistance with these kinds of tasks can be very physically taxing, and it does require whoever you are, no matter how strong, able-bodied you may be, you need some backup. So I encourage you to be thinking now about your safety net and developing your backup plan. I want to talk a little bit about the important issue of motion. Right? Motion is really essential for all of us for comfort and well-being. And as I indicated, it's not uncommon in the late stages of dementia for a person to have very limited physical movement and mobility. But that doesn't mean that they don't need to keep moving. We all need to see different things, right? Get a change of scenery from time to time, even if it's just a different room, right? Moving into different places, but also physically moving our body. So do keep in mind, I know I've been doing it as I sit here in my chair. You've probably been doing it too. People need to change their positions frequently. We can't sit, stand, crouch, whatever it might be, in the same position for too long without becoming pretty uncomfortable. So change their positions frequently. Keep them moving throughout the day as much as you can for as long as you can. And encourage, even if it's just a little change, right? Let's just stand up for just a quick moment. Be realistic about your expectations for that person. If they are no longer mobile, they're not walking around anymore, do continue to reposition them every couple of hours. If they use a wheelchair, they need to be moved in and out of that chair from time to time. If they're lying in a bed, they need to be repositioned, moved around. About every 2 hours is what's typically recommended. Watch for skin breakdown over the bony areas of the body. As we age, our fat pads move. They don't necessarily go away, they just move. So we don't have as much fat in those bony areas around the buttocks, the hips, And the areas, the coccyx, sorry, I'm forgetting the the common word for that, the tailbone, there we go. The tailbone area, the heels, the buttocks, and the hips are very prone to skin breakdown, like the development of pressure ulcers when there's not enough movement. If the blood is sort of pooling and sitting in those areas for long periods of time. So watch for the skin breakdown, especially everywhere, but especially in those areas. And look for opportunities where you can use moving and motion, either wheeling the chair into a different room, going for a drive, taking a walk, doing chair exercises or some chair yoga together, or even just sort of guided stretches together. Look for these opportunities. They not only keep the person healthy and feeling better, but they're nice opportunities for connection for the two of you as well. So a couple of ideas for some adaptive supplies that may be helpful. And I am going to be talking in a little bit here about hospice services, which for a lot of people are the source of a lot of these supplies. But do keep in mind that you do not need to be on hospice in order to have things like a hospital bed, a lift chair, for example. These are things that we can procure on our own. So just a couple of ideas of some adaptive supplies that might be helpful. Gait belts are very simple technology. It's just a simple kind of canvas-y belt that you strap around the person that gives you an extra handhold where you don't, when you're helping somebody get out of, up from a seated position, for example, out of a chair, out of the car, you have something to hold on to besides, for example, their belt buckle or grabbing their arm, wherein you might cause bruising or hurt their skin in some way. A gait belt is a very simple, again, very simple technology. You can just buckle it around the person low on their waist, and then you've got a safe place to grip and an easier way to move that person around. The use of recliners and lift chairs. This gets a little bit tricky because if a person with dementia has not used a recliner or a lift chair earlier in their life, this new movement of a seat that they're in could be frightening and confusing. But if the person has used recliners or has had a lift chair in place, it can be a huge help to you as a care partner. In the bathroom, lots of adaptive supplies that are available. This is often referred to as DME, durable medical equipment. So the shower chairs, the benches, a raised toilet seat that makes it easier for somebody to get on and off of the toilet, a bedside commode may be a helpful idea. Again, if it's not something that the person was used to before they reach the late stage of the disease, they're not likely to be able to remember how to use a bedside commode. But if this has been familiar to them, don't hesitate to bring it in and see if that's helpful to them, doing a little less walking in the middle of the night when it's time to use the restroom, for example. Speaking to that issue of skin breakdown, the particular mattress that the person uses can be very helpful. There's lots of special mattresses out there that use foam, gels, air, even water, not the old really squishy water beds, but sort of thicker mattresses that can be used to prevent some of that skin breakdown. So again, in addition to using a hospice provider to obtain some of these supplies, talk with a primary care physician about getting a referral. Often they can order a physical therapy evaluation. Somebody will come into the home and make some recommendations for equipment or supplies, that durable medical equipment that will help you with mobility issues as well as personal care. A home health care referral. These are licensed nurses and therapists that can come into the home. They can often make recommendations and help you with referrals for these types of adaptive supplies. And medical supply stores, you can also just buy them pay for them privately out of pocket. So if you need referrals to any of these types of sources, resources, please just reach out to our social work team. We do maintain lists of local providers of these things, and we can connect you to one. So I want to pause here before we talk about the transition to the end of life and see if there's any questions. I know there was one up here a moment ago. I'm gonna come back to, sorry. Please feel free to chat any additional questions as they come up. I have a question that says, if a person is asking if it's likely if our loved one lives in a memory care facility, will they need to be moved to a nursing home, or can hospice take over where they are? It's a really good question. Hospice, and I'm going to be talking about hospice in a little bit, but absolutely hospice can be provided wherever the person is. So that can be in a private home, that could be short-term while they're in a hospital, or it could be if they're living in residential care, if they live in an assisted living apartment or in a memory care facility. Hospice the person does not need to move into a nursing home in order to receive hospice services. So hospice can come in and provide services wherever the person is. Any other questions? Okay, I'm gonna keep moving along here. Now we'll talk about the transition to the end of life. The end of life for a person with late stage dementia, it doesn't necessarily look that different from the end of life from any other cause in any specific or predictable kinds of ways. Just as while we are alive, we are all so uniquely different, we all die differently as well. But let's talk about what it generally looks like when someone is beginning the transition toward the end of life. So at the transition is terminology that we tend to use. It's kind of hospice terminology, meaning the person is not yet what we would call actively dying, but they are beginning that transition toward active death. So in the transition, we are very likely to see the person sleeping quite a lot. Very little wakefulness throughout the day throughout the day and the night is very common. Much more sleeping than being awake. We are very likely to see that difficulty with swallowing that I was describing. The coughing, the choking, the having a hard time with swallowing can happen at any stage of the disease. But certainly at the very end of the disease, many people will not be able to take in food or liquid without choking, without coughing. Not to say that they're going to choke, just sort of, it sounds like pretty intense coughing. We're likely to see very little eating and drinking, and this may have been slowing down for quite some time. But in the transition toward the end of life, there's often little to no eating or drinking. The person's communication can change. Now, again, communication has been changing from the very earliest stages of this disease. The person is speaking differently, communicating differently. And that continues in the late stage of the disease as well. So a person may discontinue verbally speaking, using verbal language. They may just begin using sounds. Sometimes we see people begin to sing. They begin to tell stories. Sometimes people do actually speak more in the transition toward the end of life. So generally speaking, we can just expect to see communications are going to change. And one physical change that we often see that can be confusing and frightening to people, I just want to sort of normalize it, and you can expect to see, is what we call contractures. This is where it happens in the feet sometimes, but it usually happens in the hands, wherein the person sort of looks like they're making a fist. Their hands are just sort of curled up on themselves tightly. So contracture is nothing to worry about. Just keep the person moving, keep the hand clean, give it, hand washing and massage or using lotions to keep the person comfortable. But contracture is nothing to worry about in most cases, unless you're seeing that skin breakdown. So what might the end of life look like? So this is the phase that we refer to as active dying, the moments or hours, or in some cases, days before the person dies. So we're very likely to see a total end to eating and drinking. Minimal responsiveness. So certainly minimal responsiveness to verbal communication, but there may also not be much response to even, favorite sounds or the touching of the hand or hugs or kisses, that type of thing. Just not seeing a lot of response from the person. Very common for the hands and the feet to get cold. We often see changes in the person's skin color, not just on their face. They could get a little redder, they could go pale, but we often will see on the skin throughout the body what we call mottling, where there's sort of these patches of redness. Changes in the skin color are common, and certainly changes in breathing. So it's sort of hard to predict. Sometimes it's a lengthening of the breathing gets slower. Sometimes it's sort of a more shallow breathing. The breathing is actually faster, but it's not as deep. So very likely to see changes in that breathing. I have a question about how long these stages might be. And unfortunately, there really isn't an answer that I can give. That transition, sort of when are we in the late stage of the disease versus the end stage. The end stage, if I may, I'll go back to this slide. The end stage, or what we would call the transition, this could be a matter of days. It could be a matter of weeks. It's not usually any more than a few weeks, but it's not necessarily a very short period of time either. Kind of hedging because there's no clear answer here. But the transition is typically there's some time, right? There's a couple of days usually of this, and the end of life, as I said before, is typically fairly short, but not for everybody. I certainly have known people who were in the process of active dying for several days. So there is no normal when it comes to these things. This is one of the reasons that having hospice involved, or having an expert such as an end of life, a death doula. This is a professional that's available to sort of shepherd people through the transition and end of life process. Having an expert who's seen this before, who can walk you through the fear or this discomfort that you might be feeling, because it can be so hard to know what to expect. So I hope that helped answer that question a little bit. So let's talk a little bit about the things that need to be done after a person dies. First, it's important to follow any instructions that the person or their legal representative has given you with regard to the disposition of their remains. So if the person intended for the body, their brain, particular organs to be donated, there are often very specific instructions that need to be followed immediately after the person's death. So if you're caring for somebody who has any of these provisions in their advance directives, or they've made these arrangements, I do encourage you to look for those instructions now, get familiar with them, so that at the time of death, when you are understandably under a lot of stress, experiencing grief, you have all of that information ready. So you want to follow any specific instructions that need to be given based on what the person wanted in terms of the disposition of their remains. Make contacts with key family, friends, and supports, and that could mean anything. That can mean they're family, friends, and support. It can mean yours if they're not the same people, right? Reach out to the people that you need to know in this moment. Make sure you're getting this, you're building the support that you need in here too. It is important to notify, I mean, these are sort of in the days afterward, but notify attorneys, banks, insurance providers, the Social Security office, or any other key contacts. You will need to get a death certificate, collect those important documents, and get them where they need to go. A really important point that a lot of people I think are not aware of is everybody has a different comfort level with this, but I do want it to be said that a body does not need to be removed immediately. Right? Home funerals are really gaining a lot of traction in this country right now. Think about what they want and think about what you need. If you would like for their body to remain in the home for a few hours, even for a few days, this absolutely can be done. There's nothing unhygienic about that. The body does not need to be removed immediately, and you can make those arrangements with the funeral home, the mortuary service, to keep the person at home or wherever they were for a bit longer. And think about those grief rituals that might be helpful to you. Right? Sitting and having a continued conversation, saying those final things, whatever it might be, giving people an opportunity to come by and say their goodbyes, right? For some people, that's very uncomfortable. For some people, these grief rituals will really help them in the days and weeks and months after the person has passed away. So know what's gonna work for you. If you can, have conversations with the person now about what they want, these special instructions, these rituals, what they would or would not want in those moments. So care planning is really critically important. It's one thing to talk about all the things you need to do to tend to the person as they're transitioning at the end of life, after they have passed away, to sort of know what the person wants or to have a plan for yourself internally is one thing, but to actually pull all of those resources together, get the documents in place. This is what we refer to as care planning. Each of us has a much better chance of experiencing a good end of our life if we've done some thinking ahead about what we want, planning it, talking about it, and of course, getting it down on paper. So I want to talk about some of the resources that are available for that. Okay, so I've been talking about some of the things you might expect along the way. It's important to sort of know where the person stands or where their legal representative stands on these issues, so that you're not making these types of important healthcare decisions in the midst of an emergency, in the midst of a crisis. We don't make our best decisions in those moments, right? So think about what the person wants in terms of CPR. A do not resuscitate order is a document that typically is used within a hospital setting wherein a person can say, if my heart stops, I do or do not wish to be resuscitated. Do not resuscitate order. A DNR order doesn't necessarily cover a person at home. They are documents that are intended for licensed healthcare facilities. We'll talk next about some of the documents that you can put in place to make sure that these decisions, to make sure that these wishes will be followed. I want you first just to be sort of thinking about what these decisions might be. So how the person feels about having their heart restarted through resuscitation in the event that it stopped. The insertion of a feeding tube or intravenous hydration. I've been referring to that difficulty with chewing and swallowing. Questions about the insertion of feeding tubes come up a lot in the very late stages of dementia when a person is not able to feed themselves independently, or if they're really struggling with chewing and swallowing, having a lot of difficulty with that choking. So important to talk about, think about, and get down on paper what your wishes are with regard to the use of artificial nutrition and artificial hydration. The use of antibiotics, this one comes up a lot and is sometimes a surprise to people. If the person is in the very late stage of dementia and develops, for example, pneumonia, usually that pneumonia can be successfully treated with a prescription of a strong antibiotic. Is that what the person would want? And then finally, would the person want to be in the hospital? I think most of us, when asked, would say, of course, we would never prefer to be in a hospital. Most people want to die in their own home or in a comfortable bed and not in a hospital bed. But that can't always be avoided. And a good death in a hospital is absolutely possible. And again, with some planning and with some support and a good advocate. But the question here is more about if a person, for example, lives in a residential care facility, if they live in assisted living or they have, they're in a memory care apartment and they experience a fall, for example, it will be the facility's policy to take the person by ambulance to the hospital to be evaluated in the event of a fall, unless that person, for example, is on hospice. There are some things that we can do to prevent repeated hospitalizations for people at the very late stage of the disease. And the use of hospice services is one of the important tools that we have. And we'll talk about that a little bit more here. So here we have some of the resources that are available. You've made the decisions, you've talked about what you want, or you as a family or a group of people that have known this person for a long time, if they didn't get these documents in place, there's some of this that you might be able to do for them. What documents do you need to actually complete? So I have a couple of resources here on this slide for the facilitation of these hard conversations. Prepareforyourcare.org and gowish.org. Prepare for Your Care is an informational website where you can go, and there's a lot of really great prompts for some of those discussions and decision points that need to be made. Go Wish is they actually sell this little deck of cards, or they have an online platform as well. It's basically a game. It's modeled after Go Fish. It's a discussion game that you can use to facilitate conversations about what you don't do and don't want with regard to end-of-life care, those questions about antibiotics, questions about what you would or would not want in the way of memorial services, that type of thing. So there are some nice tools out there for guiding you through these hard conversations. You don't have to do it on your own. And then it's really, really important that once you or the person has decided what is to happen, that get documented somewhere. We have to get it down on paper. So we have other classes, other resources we can point you toward where we talk in much more detail about these legal documents. I just want to bring two of them in particular to your attention today because they are so critically important. The Advanced Healthcare Directive is a document. You can get one of these completed as part of a larger estate plan, or you can simply go online and download a very simple, what's called a statutory form for an advanced directive, complete one, get it notarized, and it's legal. This is a document that names your agent for power of attorney for healthcare. You're saying who it is that you want to make decisions for you, if that's needed. And it lays out some of those decisions that you've made. It can be very detailed or it can be very simple. It could simply say no heroic measures, or it could give very detailed examples of some contingencies. Well, I'm willing to go on a respirator, for example, for up to 3 days, right? It can be very, very detailed, or it could be very broad. It's very important that all of us, not just people with dementia, but any adult over the age of 18, have an advanced healthcare directive in place that lays out who you would want to be your decision maker and what it is that you would want them to do or not do. And then the post form, you see this pink image here on the screen. This is replicating the physician's orders for life-sustaining treatment form. Post is a form that's used in most of the 50 states. A few of them have something different called a MOLST or something similar, but most states have a form like this one. And I have a resource for you at the end of the slide deck for where you can get some of these documents, by the way. But the post form is sort of more than the DNR. A physician's order for life-sustaining treatment is a standing physician's order. You fill it out. It's double-sided. There's lots of opportunity to customize it, put in specific information. It's answers to those questions about not only how you feel about CPR, but the insertion of feeding tubes, artificial hydration, the use of antibiotics, and some other options for what are considered life-sustaining or sometimes heroic treatment measures. So you fill this out and you actually take it to the doctor and they sign it. It's a standing physician's order, so it doesn't only work in a hospital, it works wherever the person is. And it's generally printed on this bright pink paper that you see here. It's legal on any color of paper, but it's generally recommended that you print it or make copies of it once it's been signed on this bright pink paper, because healthcare providers and first responders know to look for this. This could be on your fridge, it could be in your notebook, right? If you live in a care facility, they will probably have this on file if you've completed one. It's optional, you do not need one, but certainly anybody at or approaching the late stage of dementia, we highly recommend it so that there aren't questions that need to be figured out in a crisis regarding these life-sustaining measures. And then I just want to say a quick word on the End of Life Options Act. In California, this is sometimes referred to as physician aid in dying. California is one of the few states that has an act like this, has a law like this in place. The End of Life Options Act is not something that can be applied to individuals with late stage dementia. I get this question a lot, and there's a lot of frustration around this, but the way that the act works, the way that the law works, a person has to be able to make a verbal request of their doctor. They have to make more than one request, and they have to be able to self-administer the medication that would end their life. A person with late stage dementia would not be able to do any of these things. The point at which, certainly dementia is a terminal illness, as we've been talking about, but the point at which you sort of reach that stage where the person might be expected to die within a sort of a short time frame because of the nature of the functional losses that come with dementia, the person would not be able to make this decision for themselves. So at this time, and I don't see this changing anytime in the near future, at this time, a person with dementia is not able, even when they're in the very early stages, to sign paperwork, right, get this in place for implementing the End of Life Options Act at a later date. There are several conditions where in terminal illnesses where a person does not have the ability to implement this act, and dementia is one of them. So I want to talk now about the services of palliative and hospice care. There's often a lot of confusion around these resources. They are not very well understood. Generally speaking, they are very different things, and I'll describe them each. But generally, they work the same way in that, as you see here in this visual, they put the patient and their representative, their family or whatever that relationship might be, that person is at the center of that care. And then this array of healthcare providers, ancillary service providers, which you see sort of depicted here, they circle around, they wrap around the person and the healthcare services that they receive to meet their individual needs. So we'll talk first about palliative care. So palliative care is probably the more misunderstood of these two types of care. Palliative care is medical care that is designed to address pain and suffering. It's medical treatment, it's medications, other types of therapy that are designed to alleviate pain. That could mean any number of things. Pain can be physical, pain can be emotional, and pain can be spiritual. It is medical care that is appropriate for people at any age and at any stage in a serious illness. So not necessarily the end of life, not necessarily terminal illness. If a person has a serious illness, no matter where they are, if they are suffering with pain, they can receive palliative care services. And a person absolutely can use palliative care services along with curative treatment. So unlike hospice care, wherein a person is sort of agreeing, or we're not gonna fight this disease or this condition anymore. I'm gonna focus on comfort. A person can receive palliative care services while they are seeking curative treatment for a condition. VITAS is a nationwide provider of hospice services, and they have a really great website. I have a couple of pieces of information here that I've taken from their website. A lot of good detailed description of palliative and hospice care services. And I really liked this quote that I found there. Thinking of dementia as a terminal illness from which people are dying over years instead of months allows one to focus explicitly and aggressively on a palliative care plan. I think because a person with dementia isn't necessarily experiencing physical suffering, we tend to forget that there's other types of pain that the person may be experiencing, and palliative care absolutely can be brought in. So you can request what's called a palliative care consult from a primary care physician. You can self-refer if you have straight Medicare, and often palliative care services are initiated while a person is in a hospital. So you can actually request a palliative care consult at the bedside in the hospital as well. So these are services that can be provided in any setting. Again, it is medical care. So hospice care is something a bit different. Hospice is not a place. There's a lot of misunderstanding about that. There are physical sort of standing hospice centers, but they're actually pretty rare. We only have a few of them here in San Diego County. Hospice is a concept of care, and it's delivered wherever the person lives, as I was describing before. It's an interdisciplinary type of care, so there's a primary care physician, there are nurses, there are social workers, there's chaplains, and then often there are all of these ancillary providers that you saw on that slide a few minutes ago. So we will see aromatherapy, pet therapy, there's all sorts of volunteers and other types of services that can sometimes be brought in, depending on the particular hospice provider. So hospice care is different from palliative care in that it is designed to provide comfort and support to a patient and their families when there is a life-limiting illness. So generally speaking, we're looking at a person who could be reasonably expected by their physician. The physician is the one who makes this determination. They could be reasonably expected to die from this condition within about a 6-month period. So doesn't mean that they have to. People often do live longer than that 6-month period. Their health and their functioning and their well-being improves because of the hospice care. People can be recertified for hospice services to be extended. Excuse me. It can be recertified, or hospice services can actually discontinue, and then they can be started back up at a later date. So there's a lot of great benefits to working with hospice. Often people are kept much more comfortable. They get a lot more personal attention because doctors, nurses are making regular visits. And we do see the important benefit of reduced hospitalization. So I was using that example before of a person who's living in a residential care facility who's having repeated falls, just as an example. And the administration is, following guidelines and having that person sent to the hospital to be reevaluated anytime that they fall. If a person is on hospice, that can actually sort of stop that cycle of repeated ED visits or hospitalizations, because those services can be provided where the person is. Hospice is a Medicare benefit. It typically, at least the way that it works at the moment, there are changes on the horizon, but at the moment, a person essentially signs their Medicare benefits over to the hospice, and the hospice becomes their primary provider of healthcare services. So the hospice then will cover expenses related to equipment, medications, therapies for comfort, for example, for anything that is related to their specific hospice diagnosis. So it doesn't cover everything, but it will take over and cover a lot of otherwise out-of-pocket expenses for folks. So I have a question here about whether there are any locations where a hospice will not visit. The limitation there is there's not much. Hospice services, as I indicated before, can and usually are be provided within a private home, in a hospital, in a residential care facility. In some cases, a small board and care home or an assisted living facility. So they have to have a certain number of what are called hospice waivers. So skilled nursing facilities, this happens as well. They have a limited number of beds that can be, quote, hospice beds, meaning they've got permission for hospice providers to come in and provide those services within their facility, but it could happen that a particular community, all of their hospice beds are full, meaning they only have permission, for example, to have, maybe 10 people that are on hospice at a time within the facility, and they have reached that limit. So that's really the only sort of specific time or place that hospice could not be provided. When you're looking into residential care options, ask them about the availability of hospice. And do be aware too that you don't have to work with any particular hospice provider. So if, for example, you're a patient with Scripps, of course, your doctor is very likely to recommend Scripps Hospice, but you can choose to use it or not. We have many wonderful hospice providers here in San Diego County. This is another resource our social workers can connect you to if you're looking for those resources. And typically, you have a choice in what hospice you prefer to bring in. Okay, so there is some confusion around this. I have heard it said many times that people with Alzheimer's and other types of late stage dementia are not eligible for hospice care. Absolutely not so. Every diagnosis has its own eligibility criteria. So the Medicare basically sets a set of criteria that a person has to meet, and each particular diagnosis, if it's a particular type of cancer, heart failure, dementia, whatever it might be, each of those diagnoses has its own set of what are called hospice indicators. So I've listed for you here in very general terms the eligibility criteria for a person with dementia, with a dementia diagnosis, what is required in order for them to be eligible for hospice. They have to be unable to complete the activities of daily living, those 6 activities that I showed you earlier, without assistance, and be unable to communicate meaningfully. So communicating meaningfully is generally gauged by the extent of the person's vocabulary, how many understandable words the person is able to communicate. If the person has what's called an intercurrent illness associated with advanced dementia, other conditions that are complicating the provision of healthcare, so pneumonia, septicemia, those decubitus ulcers, the skin breakdown, the pressure sores that I was describing. If the person has advanced dementia and is experiencing any of those types of illnesses, they are eligible for hospice services. If they have impaired nutritional status, so that could be that difficulty with swallowing or a refusal to eat, or if a person experiences weight loss of 11% or more of their body weight, then that is considered impaired nutritional status and they're eligible for hospice services. Or if the person has comorbid conditions that significantly impair their health and functionality. So this could be heart disease, COPD, diabetes. They have other health conditions that are sort of synergistically, the dementia and the heart disease, for example, are making each other worse. Right? So absolutely, this all may sound a little bit extreme, but in the late stage of dementia, most people in the late stages of Alzheimer's and other types of dementia are absolutely going to be eligible for hospice services through one or more of those criteria. So how do you actually initiate palliative or hospice care services? First, it's just important to know that this is available to you, that this is a resource. Both of these types of services are sorely underused in the United States today. I think the average length of time that a person uses hospice services in the US today is something like 7 days, if I'm not mistaken. It's very short. And in fact, both the patient and the members of their support system could be getting so much more benefit from these services, both palliative and hospice services. If they could identify when it was time for these things and go ahead and make that request. So I encourage you to don't rely on the doctor to bring this subject up. Doctors are not all knowledgeable about palliative or hospice care services, or if they are knowledgeable, they're not necessarily comfortable making this recommendation to their patients. And it is absolutely okay for you to bring it up. Hey, doctor, I'm aware of how palliative and hospice care services work. I'm afraid that my person may be experiencing some pain or discomfort, and I want to keep them comfortable. I want to talk about hospice services. You absolutely can. You can get a referral from their doctor directly, or you can contact the hospice yourself. You can make that initial contact and they can seek the referral from the physician. So it takes a little bit of work, but absolutely you can seek that referral on your own. So at that time, they will explain to you their admission procedures. They're all a little bit different, but for the most part, most of them are going to have an RN, a nurse that does an initial visit to evaluate that the person is eligible, that they meet those hospice indicators for that particular diagnosis that I was describing. There's generally a home visit, or wherever the person is living, someone will come and you don't have to go to them, is what I'm saying. They'll come to you and complete that in-person assessment, start that admission procedure, and then you are assigned a case manager. That's the terminology that's used in most hospice. You'll be assigned a case manager, and then that person works with you to coordinate all of these ancillary services, the social workers, the other volunteers that might be coming to visit, for example. That person becomes your primary point of contact. And as I mentioned before, a person absolutely can be recertified to continue to receive hospice services after that 6-month period. And I think the recertification is usually for about 3 months at a time. Okay, before we talk about strategies for coping and resources, any other questions on this transition to the end of life or care planning resources? Okay, had some coming in as we've been going along, so great. So let's talk a little bit about coping. Here's that important topic of grief again. Again, there is no universal experience what grief is or is going to look like or should look like. There is no standard timeline for how it happens, and often it's not linear in most cases. You don't just stop grieving someday. It kind of goes in circles and comes in waves and can be unexpected at times. So you really have to release yourself of expectations around grief, right? Both your own, what you think grief should look like. If you've experienced it before, you might think you know what you're in for, but also releasing yourself of other people's expectations of what your grief should look like. The best coping strategy that we have, unfortunately, is just to feel it, right? To feel those waves of those emotions that I was talking about before, to feel the pain, to acknowledge this is affecting my sleep, my appetite, right? To feel a little bit of that anguish and to allow yourself to fully feel it, but only sometimes. Right? Have outlets for support and relief. Figure out the types of support that you need so that you have the time and the capacity to do some of the things that you know can give you a break from those feelings of grief, the things that make you feel good. And again, I just want to emphasize, we need to address these needs now at every stage of this journey. Grief doesn't just happen after the person has died, right? So think about the things that make you feel good. I have a wonderful colleague who put this list together and I love it. Turn on your favorite music, eat all the chocolate, pull the weeds, organize your tools, smell something that makes you smell good, find a patch of sunshine, putting on a favorite piece of clothing. There's a good self-isolation strategy for all of us right now. Have coffee with a friend, or these days we have to have virtual coffee with our friends, right? Think about the things that make you feel good. And I encourage you on that piece of paper that you've been jotting down notes about your person, think about yourself here for a minute. Think about some steps that you can take to improve your own health and your own well-being. Probably no more important than right now. So here we are. This is Alzheimer's San Diego, a nice visual representation of the array of services that we provide. Unfortunately, because we are not able to provide in-person programming at this time, a lot of these supports and services are not currently available, but clearly you found our online education program. We have online support and discussion groups that are forming. We're very excited about that. Our team of social workers, our dementia experts, are as available as ever to provide you with whatever support you need. So all of these programs and supports, we fully intend to have them all back online, up and running in as soon as we safely can. But in the meantime, I really want to encourage you to stay in touch with us. There's a lot of great information and support available through our website. We have some wonderful tip sheets. We have a video library that's growing all the time. And again, our team of social workers, our dementia care consultants, are just a terrific resource. You can reach them Monday through Friday by phone, send an email, or even just live chat with them through our website to connect to any of these resources that I've been talking about, to seek out emotional support, whatever it is that you need, we'll help you connect to it. So in review, we've talked about the changes we can expect to see, ways of connecting and communicating, keeping the person comfortably, what to expect at the end of life, how to plan for a good end of life, and hopefully giving you some strategies for staying well and healthy yourself during this journey. For more information, here, and again, I am happy to email copies of these slides to anyone who needs them, so you don't need to write this all down furiously, but some resources for finding out more information about palliative care, about hospice services. The Coalition for Compassionate Care has great information about end-of-life planning. And then Post California, you can actually download that document that I was talking about earlier. So thank you so much for coming, for sharing your lovely insights and ideas, for asking your great questions. I would love to get your feedback. What I'm going to do in the chat right now, I'm going to send out a link to a very short online and anonymous survey. Would love to hear your feedback on the class, ways that we can improve it, and any ideas or suggestions you have for additional topics that we could cover. I'd love to hear your feedback. Here's that email address again if you want to request a copy of the slides from today. Some information about our next two scheduled upcoming online education programs, Living with Memory Loss. This is both for care partners and for persons who are living with dementia. And then there's that communication skills class that I was talking about before. So the details are up on our website. So I'll hang around for another minute or two. If you've got any questions, oops, not sure my chat worked here. Let me try this again. Send you a link. There we go. There's a link to that survey. I'd love your feedback. If you've got individual questions for me, please send them along. But by all means, don't hesitate. Reach out to our team of social workers. They're here to help as much as ever. And until we can all meet face to face again, I hope that you'll all stay healthy and safe. And take good care of yourselves. I got a question about someone who missed the beginning of the program, the first few slides. Just send an email to that address that you see on the screen right now, education@alzsd.org, and I'll be happy to email them to you. And we will, again, be posting a recording of this program just as soon as we can get it up. So thank you all so much. It was really great having you. Again, I thank you for being willing to sit through these hard topics. I know they're hard to think about and talk about. It's much appreciated, and we really respect and appreciate all that you do. So thank you.